Good evening and welcome to the first conceptual basis of urology course of 2023, and belated Happy New Year and best wishes for all our faculty who are involved, and all to the delegates of the conceptual basis of urology course, where we are fortunate today that we have two presentations by two leading authorities. Professor Athanasios Papasaris, Professor of Urology in Athens, Greece, is a well-known figure in the world of endourology. He's a adjunct professor in many international universities. He's a recipient of many awards and from the World Congress of Endourology, and a regular speaker in meetings in Pakistan. So I'm grateful to Thanos for his valuable contribution. He's going to talk about PCNL tips and tricks and pitfalls. Our second speaker, and we are welcoming Professor Greg Carter for the first time in the conceptual base course. And Dr. Carter is from United Kingdom, and he's going to talk about the second most important endourological intervention for urolithiasis, which is flexible ureteroscopy. So I think it will be a very rich session. My apologies that I'm not going to be present throughout the presentation due to some other commitments. And I'm grateful to my colleague and friend, Dr. Zishan Aslam, for moderating this session. And I'm hopeful that there will be a very enjoyable 1 hour from the two leading authorities on the subject. So thank you very much, Zishan, for taking over, and over to Zishan for conducting this session.
Well, thank you very much to the Conceptual Basis Urology webinar series and the team. And as already been introduced, our first speaker by Professor Hamad Attar. I would just like to invite Professor Papasaris to speak on PCNL tips, tricks, and pitfalls. Please share your screen, sir.
First of all, I would like to thank you for the great invitation. For me, it's a pleasure to participate in this very educational series. I know a lot of you, and we meet regularly during congresses. Now we're going to have live chances to meet each other, and I hope that I'll see most of you during the EAU Congress in Milan. So I'm going to speak the following 20 minutes regarding PCNL, regarding PERC, which is one of the most demanding operations in endourology. I was very lucky to be trained with no buckles in London. I did 2 years official endourology fellowship, and I practice endourology in Greece and other countries. So it will be very interesting to interact and to see how we are doing the same operation in different ways. So first of all, I would like to thank my friend, Professor Hammond, that already opened this session. He's very well known, and I know him for more than a decade. And for me, it's a great honor to be with him either live or online. Also, Aga Khan University and the Association of Ureteroscopy House. So for you that haven't visited Greece, we are in the middle of East and West, and we have a lot of stone patients, as probably you have. That's why we've formed the study group of urolithiasis, Southeastern Europe, the SEGUR group, and we have published several articles regarding urolithiasis in the Balkan area. As we all know, when we're going to treat a stone patient, we have to decide among all these three modalities. It's very important to be able to actually offer all these three treatment modalities, because studies have actually shown that we usually offer what we have or what we can do. And in some cases, we should refer a patient for the specific treatment according to the parameters that we should take into account. The interest for PSWL is decreasing. However, the interest for PERC and RIRS is sky high. And we can see this with publications. Of course, as I said before, parameters that have to be taken into account in order to decide which of the three treatment modalities we're going to perform have to do with the stone, size, number, composition, with renal anatomy. For example, if you have UVJ obstruction, if you have the reticulum, if you have several anatomical variations. And of course, with the patient per se. If we've got, for example, a patient who cannot stop his anticoagulants, then it's not advisable to perform a standard PCNL. You go for RIDS, for example. And also we have some different things that we have to take into account if we have a UTI. For example, it's an issue what we're going to do if we have a positive urine culture and we have a struvite stone. That means we have an infectious stone. Usually we prefer to go ahead with a sterile urine analysis, but in some cases this is not easy. So there are several tips and tricks that we can go ahead with. For example, for this specific issue that I've mentioned, if we have an infectious stone with positive urine culture that we cannot treat with antibiotics, we have to admit the patient, give IV antibiotics. We can monitor daily the leukocytes in the urine. And there is a window where usually we can operate with the minimum pressure and have the best result. But all these cases go with experience. And experience comes with specific training, with fellowships. And that's why we can see that urologists that have undergone official urology fellowship will actually practice complicated urological surgery, and challenging cases will be dealt by the minimal invasive operations. In contrast with other office urologists that would, for example, advise ESWL, which is an easy procedure. So regarding our main topic, PCNL, and from PCNL, standard PCNL, it's very important to know the general position of the patient. It's very, very important to prepare your patient yourself, to understand that you have to take into account that we should protect everything, and we should keep everything free from raised pressures. And there are several things that we can use, like these silicone items. For the head, we have several tips and tricks, like the prone view helmet. As you can see, it protects very nicely the head, and also with this mirror, the anesthetist can actually control the tube. There are several mattresses, like this Montreal mattress, where we actually avoid increase intra-abdominal pressure because of this part, which is empty. This is a position where we also elevate the kidney if we want. Sometimes we flex the table and there's no need. And all depends with our experience, and everything should be personalized. We are in the era of tailored medicine. We have published the improved patient positioning, which reduces complications in prone PCNL, and that is in 2009. There are some awkward positions that we may need to adopt in order to treat specific rare cases, like very, very obese patients, like patients that cannot have general anesthesia. We cannot have a patient under regional anesthesia on the prone position. And we published 27 cases by doing them in the lateral decubitous position. And a very good case is the spina bifida patient with a big renal pelvic stone. It's important when we see the patient and when we actually see the CT to have the images and the position where we're going to perform PCNL. And we can see nicely the window on the prone position, the supine position, or the flank position. There is a trend regarding modified supine positions like the Valdivia one. But as we can see at the classical Valdivia position, the area where we can puncture is quite narrow. And that's why we have several variations. And actually, we propose the Bart's technique position where we have a better space where we can do our percutaneous access. And this was our first proposal. And in 10 years ago, we actually published the Bart flank-free modified supine position, where we can see that we elevate these two areas. And these are sandbags that actually gives you a very, very nice area to do your percutaneous access. We compared this with other positions, and we actually published a nice review on the positions. If you want to make the most secured entry from the percutaneous access, you can control this with your flexible ureteroscope. We have, as we all know, the endoscopically combined intraoral surgery. Nice trick is to advance a very stiff wire and actually go outside the kidney, and then you can follow this wire to go percutaneously. It's not very easy because the scope may bend, but it's a nice trick. Very safe way to get in is by seeing your pathway. So following the laparoscopic rules with the first trocar, we can use the old seeing needle with the camera as we go in. But to be honest, it's quite an expensive gadget to have visual dilators. There are studies regarding the exact point and the way that we function, and there are softwares that actually take into account our fluoroscopic images and can guide the needle to the exact position, because one of the most important aspects of PCNL is to get at the right point, at the right calyx, at the right angle and depth. And you can see some images. To be honest, for us of performing PCNL many years, this may confuse us, such as the iPad fusion image, where actually we can, through fusion of the pre-op 3D CT images with what we see live. And this was presented by Rasweiler several years ago. Quite interesting is to have a needle that punctures and has a GPS tracking system, but this is not still commercially available. We start with our needles. We need all our gadgets, all our disposable items, and the most important part following puncture is dilatation. Balloon offer us a quite quick and safe dilatation over ambulatory renal dilators. However, be careful because the balloon has a radio marker, and there is 1 centimeter where exactly you are not inside the renal collecting system. So, for example, you may have a staghorn. At this point, the tip of your balloon may be stuck, but your amulets cannot be advanced over here. It can be advanced only up to the radio marker. So you need a few millimeters to get inside the collection system. And that's why the metallic dilators are more precise in this aspect. We may use an occluder catheter to dilate the renal system, the collecting system with a balloon at the UPJ, but be careful because you may inflate the balloon and you may tear the UPJ. And this has happened, and also it happened in a solitary kidney. So there are disasters that you need to be aware of. I usually don't use an occluder catheter, or if I use one, I'm gonna inflate the balloon inside the renal pelvis. The dilator sheaths are used in order to actually advance the second wire. So if you have a safety wire, you put the dilator sheath, take the inner part out, and then through the outer part, you can advance your working wire as well. So it's very important also to decide if you're going to do the standard PCNL up to 28 to 30 French, or mini PCNL, that means below 18 to 23 French. You may have a staghorn, and you may actually decide to do different procedures in the same patient. But to be honest, mini PCNL is more to compete with rears. If we have a staghorn, you should go with standard PCNL. But it's good to have mini PCNL instruments inside. There are several actual proposals regarding companies and sizes. And there are some kits where we can have a lot of disposables, and this would be good and cost effective. This is another a nice actual needle to cut the fascia, because sometimes we may have difficulties to advance the amulet. It's good as you are juniors to start with an easy case, and an easy case usually is a solitary renal stone up to 2.5 centimeters, where you have a simple collector system. You may know this with a 3D CT prior to the operation. We dilate, and we can see nicely that there are no sharp angles. All that means that if you go into the lower calyx, you may access the renal pelvis and the stone. You should be careful, because in such cases that you believe they are simple, if you go straight to the stone and it's in the upper ureter and you use a master bifoclast, you may push stone fragments down to the ureter. So it's advisable to retract the stone in a place where you can control it better than to work towards the ureter. Usually middle pole or upper pole punctures will give you the opportunity to access most of the stone. Of course, be careful, because by puncturing the upper pole, you may have issues with lungs, and it's good to collaborate with your anesthetist. When you're going to do the puncture, we should have the anesthetist to help. Empirically, you can do the 45 degrees horizontal and transversal puncture. So you actually go in these two planes, and slowly you advance, like when the plane is touching ground slowly. But always you need to think through the 3 dimensions, and that's why it's advisable to rotate the C-arm. So you may go slowly inside. Initially, you may move the kidney. That means you're in the right direction. It's good to puncture the middle of the calyx. And once you're in, you may see gluteal or urine or whatever you inject from below, from your open-ended ureteric catheter. Now, the safety wire is usually a soft wire, little wire, and it's good not to have a curve. And it's good to drive it down to the ureter. So these angulated open-ended ureteric catheters, like interventional cardiologists use, may easily drive the wire down to the bladder. We may use, as I said before, the second working wire, which should be the stiffer wire. Or you may use only one, but it's safer to use 2 wires. And once they are in the ureter, you can go ahead, and it's easier to dilate them with metallic or Teflon dilators, because you go over a stiff working wire, and you don't have, for example, a curve inside the kidney, the upper pole, and you push, and you may go. So you can push once you have your wires inside the ureter. Here you can see that we use a balloon dilator, we inflate, we have this ring sign of the fascia. If we increase the atmospheres, this will go away, and this is the point where we can advance the amplatid. So it's not very close to the stone, but as we went through the calyx, we are in the calyx, and we'll follow the wire and we'll see the stone. We may wash out fragments, clots with a vacuum effect, and a very good modality to break the stone fragmented is the master lithoglass, which combines ultrasound and pneumatic modality. There are several other modalities, like the shock pulse with a very efficient ultrasound probe, but it depends what you have and what you can use. To take out fragments, you can use a basket like this, because you need to send fragments for stone analysis and culture. If you use the 3-prone grasper, be careful, because you can see only the 2 of the 3, and it's good to rotate before retracting the fragment. Otherwise, you may be stuck, or you may be tearing the urothelium. If you are using a laser, it's good to stabilize the laser, and these are several disposables. And there are several publications that may help you not to have fragments floating around. It's good to have on site also your flexible cystoscope, which will be your nephroscope. And the results should be stone-free 100%, because if you have fragments, especially infectious stones, you have recurrence. Now, in case you have Staghorn, you will need to do multiple accesses, and it's advisable first to put your wires in and then dilate. So in this case, there were actually 4 wires to the ureter, and we decided to go ahead with 2 or 3 dilatations. At the end, you need to leave a nephrostomy tube. It could be the Malacot, it could be something else, but it could be only for 1 day, so that's not a great fast. Now, regarding tubeless, it's important to note if it's with a JJ stent or with nothing. And sometimes there are several tips and tricks to decrease bleeding with in hemostatic flags. So that's all regarding the technique. I'll quickly go through the publications for complications. One of the most serious complications is bleeding, but only in a small percentage you may need to transfuse or do selective embolization. That's very important to have at the same hospital interventional radiologist, or at least be able to refer the patient. Regarding respiratory complications, they may happen if you do an upper pole puncture. And a very serious complication is colon perforation, because you need to early diagnose and treat it. The good thing is that usually, conservatively, we will treat this complication. And remember, it's usually left side thin patients. These are a couple of images after angiogram and with embolization. We have treatment of fistula pseudoaneurysm. These cases, the bleeding is not immediate. It could be a couple of days, or it could be when the patient has been discharged. Some other disposables that they are good for you to be on board. And it's advisable, and if it's possible, to have a simulator. In London, we had a postgraduate simulation center where we had the Ureteroscopy mentor, where actually we could practice as residents, SHOs, SPRs before going to theaters. And actually, we published this in the past. So it's very important in this demanding operation to collaborate with each other, and that's all from Athens, Greece. Again, it's a pleasure to be part of this prestigious educational series, and please feel free to contact me or to discuss whatever you want. Thank you very much.
Thank you so much, Professor Barros, for such a wonderful talk. Just for introduction, my most work is around kidney cancer. So PCN is always such a challenging topic for me to grasp, and there were so many concepts that I had clarified. Thank you very much. But I'm sure among our audience, there must be so many of our colleagues doing PCNLs regularly, and any questions would be really, really welcome. Sharif, we would have audio on for our colleagues if they wish to ask a question directly by audio.
Sure.
Okay.
Hello. Hello.
Hello. Hello.
Hello. Good evening.
Good evening, please.
Yeah, I'm Dr. Ataur Rahman from Peshawar.
Yes, please.
Yeah, my question is, how are you going to manage colonic perforation following PCNL? And during making a track, you make a perforation, how would you manage that case?
So, first of all, it's important to diagnose this early enough. And ideally, if you puncture and you put your contrast and you are in the colon, you won't dilate. So a colonic perforation just by needle is not an issue. In most of the cases, we dilate and we go in and we see colon, and this is where we usually panic. In such cases, you need to separate the two systems. That means that you need use your percutaneous access and put your nephrostomy tube as a colostomy tube. You need to put a JJ stent, you need to put a urinary catheter, and this separates the two systems, urine from feces, and usually you retract slowly the tube, the percutaneous tube, and it will heal. And this is the majority of the cases. In cases where we have peritonitis, then you need to operate, or when the patient becomes septic. In London, we had 5 colonic perforations during 20 years experience, and 4 out of 5 were treated, as I mentioned, conservatively. Only 1 case we need to do a laparotomy. And most of the cases were, as I mentioned, patients left side, thin patients. And to be honest, these cases were when we started to do supine PCNL, we were not very experienced with ultrasound guided puncture. But if you are very experienced with ultrasound, you should be able to identify the colon with the ultrasound. Because we were using both ultrasound and fluoroscopic guidance, and we're not very familiar with the landmarks during supine PCNL, we had these cases, most of the cases, but we were able to recognize them early enough. I hope that I answered your question. Thank you.
Thank you.
Professor Papasoris, this is Dr. Nazim from Aga Khan Hospital. Thank you for the very elaborative talk. And I would like to ask you, I think the most of the PCNLs you do is in the position. So is this your preferred approach?
Yes, to be honest, I was taught PCNL on the prone position, and I prefer this. But also I do modified supine positions, especially when I need to go from above and from below, if we have both ureteric kidney stones. But usually we do what we are most familiar with and we are most happy with. And there are not many contraindications for prone PCNL. Of course, if you have started your practice with supine, it's perfect. It's a very nice operation. There are some advantages. It's more comfortable operation. But myself, I'm a fan of prone PCNL, and usually I do cases which are Staghorns. These are referred to me.
So I mean, there are different approaches to the puncture. So you can have triangulation technique, you can have, bullseye technique, you can have advancement technique. So for the residents, which one would you prefer? Obviously, once you are an expert, it doesn't matter. But what would you advise to the junior residents? Which approach should be good for making an
Yes, this is a very important practical question. One of the safest and simplest techniques for puncture is the bullseye technique. But you need to be aware of radiation and to protect your hands with the radioprotective gloves. Triangulation technique is also good, but I believe it's more complicated. A very nice simplified technique is the biplanar 90 degrees technique, which was published 2 years ago in Latin America. And it's a simple technique where you have your C-arm and then you rotate it 90 degrees. So with the first 0 degrees, you have 1 point. And then you rotate the whole C-arm 90 degrees and you have the depth. And when the two lines are crossed, you can go ahead. So you can read this technique, the biplanar technique. I usually use this for the supine functions. But all goes with experience, and it's not only where you're going to puncture, it's also how many attempts you're gonna do, and if you are rotating the CR, because one of the mistakes that we do is that we don't rotate the CR because we believe we are experienced. So we go with one try, again, one try. And why don't we rotate the CR? Because many decades ago, when they did PCNL, they had a fixed CR on the table, on the operating table, which didn't move at all. And this was a bad habit. But now with the CR, you need to rotate it. Thank you.
Thank you so much, Professor Papasaurus, and our colleagues for their input. So we will move on to the next talk of the webinar today. And it is an absolute pleasure for me to invite my very own colleague, Dr. Greg Kata. Dr. Kata, who trained in Poland in urology and moved and worked almost these 20 years in Scottish region, and is one of the most effective trainees in the region, and has trained several residents in complex endourological procedure. One of our Trainer of the Year award winning consultants as well. He has also been involved in our faculty for the cadaveric course, where access into the embalmed cadavers into ureters was almost totally dependent on Dr. Kata's presence. So it's an absolute pleasure to have you, and he will be speaking about flexible retrograde intrarenal surgery. On to you, Dr. Kata.
Okay, can you see my slides?
Yes, thank you.
Okay, thank you, Zishan, for your kind words. And I would like to thank Professor Ater for giving me such an opportunity to share my thoughts about ureteroscopy. Thank you so much. And I must say, I'm also privileged to share my experience next to Professor Papasaurus. And I think it is second time we speak together, and we met in Warsaw years ago. Good evening, Atanas.
Yes,
so,
yes. Thank you.
Let's see if it works. Okay, I do not work with any companies, so my disclosure is no financial relationships. And I have decided to change the way I talk about ureteroscopy. I won't be telling you how to break stones. And of course, I share with you some tips on procedure, but on procedure safety. So that's why I think we can change the topic to the rules to always being a gentleman doing ureteroscopy. And as you know, flexible ureteroscope is older than rigid or semi-rigid ureteroscope. And first one was designed by Marshall in 1964, and it was flexible endoscope with no working channel, with no channel for irrigation, and they use it to assess ureter or pelvic ileal system during open ureterolithotomy or pylolithotomy. Proper flexible ureteroscope was developed by Takayasu in 1968, and the modern one was built by Bagley in 1980s. So you can see the first semi-rigid ureteroscope was built in just 1980s by Enrique Perez Castro and together with Karl Storz. So surprise, flexible ureteroscope is older than semi-rigid ureteroscope. An idea of ureteroscopy is that we do everything under eye. So as Perez Castro said, in hands of skilled endoscopists, the rate of complication should be fairly low or even very low or minimal. Oops. So when we speak about safety of ureteroscopy, first of all, we have to speak about vision, and vision means good irrigation. However, the better irrigation we are trying to achieve, we increase pressure in collecting system. Of course, irrigation and pressure depends on accessories. Irrigation and accessories can change temperature within pelvic ileal system, and of course, temperature and pressure in pelvic ileal system means safety of procedure. So that's why I would like to focus just a bit on safety and scopes navigations. Confucius used to say a wise man is never ashamed to correct his mistakes, but I think what, as endourologists, what we have to do, what we have to try to do is trying to do our best to avoid rather than correct our mistakes. So my first advice, I do not use a lot of x-rays doing ureteroscopy, but my big advice is never do ureteroscopy with no C-arm in theater. You can have hundreds of cases, you don't need it, but when you need it and it's off, then you regret it. I do agree that we need to know anatomy of upper urinary tract system doing flexible ureteroscopy, but I would not carry on with retrograde ureteropylogram on every patient just to see where I'm putting ureteroscope. I do it under eye, so I know where I go. And as you can see from these pictures, retrograde can end with backflow of contrast and urine into tubules or even veins, and can look such scary. So I don't think we need to do ureteropylogram on every patient. So let's talk about irrigation. I've been using both saline and water, but my advice always use saline. I have never seen post-URP syndrome after ureteroscopy, but I saw a couple after PCNL. How shall we use irrigation? Shall we use just gravity flow or pump? It is an experimental study, of course, but the normal intrarenal pressure of fluid or urine inside is between 0 and 20 centimeters of water column. We can observe reflux into tubules when pressure reaches 27 to 41 centimeters of water column. Backflow into veins happens when pressure reaches between 40 and 68 or 70 centimeters of water column, and we can rupture calyx or fornix of the calyx when pressure reaches 81 to 95 centimeters of water column. Now, we know that irrigation flow just greater than 6 milliliters per minute opens our ureter, and when you do ureteroscopy, ureter is quite wide open. Just excuse me. And we have to be very careful because relationship between flow and pressure is linear. So the more flow we get, the higher pressure is inside the pelvic ileal system. So let's speak about just standard scenario. We've got ureteroscope with 3.6 French working channel. We've got laser fiber of 200 micrometers inside. And when we set up irrigation flow on between 7 and 8 milliliters per minute, then just to have such a flow, we can keep irrigation back and gravity at a level of 60 centimeters of water column above tip of ureteroscope. Just increase flow to 14, 15 milliliters per minute, back goes up to 100 centimeters, and irrigation flow of just around 40 milliliters per minute, back goes to 300 centimeters of water column. Oops. Now, irrigation levels or irrigation can be nicely increased when ureteral access sheath is inserted, and we can keep the same intrarenal pressure or even lower intrarenal pressure. That one is a nice study from Traxer's team, from quite recent one from 2021. and they used a sensor wire with a probe which can measure pressures within renal pelvis at the time of ureteroscopy. You can see A means baseline pressure before administration any irrigation fluid. B, pressure increased when we start irrigation fluid, constant flow of irrigation fluid at pressure of 80 centimeters of water column. When we use hand pump, you can see on C pressure goes up immediately. When we keep on constantly pressing pump, so trying to get higher pressure for longer time, you can see pressure goes up, but not so much, and it is picture D. And picture E is pressures they measure during fragmentation of stone. What's very scary is, as you can see, regardless whether we've got axis sheaf or not, and whether we've got bigger or smaller axis sheaf, maximum pressure peaks are very high. It's over 300 or even is reaching 400 centimeters of water column. So from that study, we can say, yes, our ureteroscopy can be a danger to pelvic cell system and kidney. A conclusion from that study was that when we are using or not using axis sheaf, when we are using manual pump support, pressure goes very high regardless on axis sheaf we are using or whether we do not use axis sheaf. Another study assessing impact of intrarenal pressure on renal parenchyma is the one from Monga team, and it is also quite recent. And they mixed the irrigation fluid with ink, and they assessed how deep ink gets into renal parenchyma, and percentage means depth between calyx and renal capsule. And you can see at pressures of 200 centimeters of water column, if we do not use axis sheaf, ink went almost up to or almost towards renal capsule. So we can cause really quite significant damage to kidney doing ureteroscopy. Another study trying to see different sizes of axis sheaf and impact on pressure within the kidney. And they used standard Storz fiber optic ureteroscope and 200 micrometer laser fiber. Irrigation bag was at level of 100 centimeters of water column, so they got irrigation around 10 and 15 milliliters per minute. And intrarenal pressure was much higher for smaller axis sheaf with inner diameter of 10 and outer diameter of 12, comparing with 12 and 14 axis sheaf. And you can see 14, 15 is acceptable pressure, bearing in mind the previous study I told you about pressures and damage to renal parenchyma. Now, when we stop seeing very well, we are getting frustrated, and our first attempt is to increase pressure within collecting system. Does it necessarily mean that it is a problem of poor irrigation? No, maybe we over-distended kidney. So we have to be aware that trying to increase or keep on increasing pressure of irrigation fluid, we can almost reach pressures of over 400 centimeters of water column. So first, I think, is to assess what's happening, and maybe with over-distended kidney before we take a pump or we'll ask for pressure to increase. Another study assessing axis sheaf suggests that regardless axis sheaf is placed or within proximal ureter or renal pelvis, there is intrarenal pressure reduction up to 75%. Is it true There are a couple of clinical scenarios when we place access sheath into ureter or even ureter without access sheath, which do not confirm that at every time placement of access sheath in proximal ureter is beneficial. So let's say first scenario, we've got wide open ureter, for example, pre-stented ureter. Ureter is nicely accommodated ureteroscope. There is a brilliant flow of fluid at the time of ureteroscopy. So I think in such a scenario, we don't need to put access sheath and we can do sheathless and wireless procedure. When ureter is wide and we place access sheath into proximal ureter, yes, indeed, we've got good drainage, but I think chance to retrieve stones is getting lower because access sheath itself reduces lumen of ureter quite significantly depending on size of access sheath. However, when we've got tight ureter, and first, when we place access sheath at ureteropelvic junction or in renal pelvis, then indeed we've got a very good flow or very good drainage of irrigation flow. We are just retrieving stones with no touch of mucosa because access sheath is sitting in pelvis. And also, I strongly recommend putting access sheath straight up to renal pelvis or ureteropelvic junction when we treat upper urinary tract urothelial cancer. So, however, in contrast, if ureter is tight and we leave access sheath somewhere in proximal ureter, still ureter is tight between end of access sheath and ureteropelvic junction. And when we place ureteroscope into tight ureter, we completely stop irrigation. So I do not agree that placement at ureteropelvic junction and placement in proximal ureter are similar with regard to drainage or flow of irrigation fluid. And of course, the worst scenario, ureter is too narrow to pass ureteral access sheath. So then I always stop and stand patient and bring patient back within 2 or 3 weeks time from insertion of stent. What's also important, in the past we used to say when we deflect ureteroscope, we dramatically reduce irrigation flow. However, the most recent studies confirm that deflection decreased flow only by 5%. That study also confirmed that oval-shaped working channel delivers better irrigation flow comparing to circular working channel. So what we can use, we can use pathfinder pump, we can use syringe, you can use a pedal-driven pump, but I think all of them increase flow of irrigation fluid and pressure too much. The only thing I'm using a pump we are using for IV infusions. However, still, we don't know whether the pressure we can see on that monitor is the same pressure we are getting at the end of ureteroscope. Of course, we've got devices, and that one is a device developed by Rocamet and Professor Traxler, which heats irrigation fluid, as well as you can adjust the pressure of irrigation flow you would like to have. And I understand that adjustment considers pressure at the tip of ureteroscope, not pressure which is getting into scope through the tap. Still, the way I'm using simple way. I'll just withdraw ureteroscope from patient and observe flow of irrigation fluid, saying most likely it's too high, it's okay, or it's too low. And also after insertion of every instrument, after insertion of laser or insertion of basket, I'm checking flow from ureteroscope. It's also quite important because very often you don't have any flow, and person which is responsible for putting pressure on pump is saying, yes, pressure is very high, but at the end, you can see just the drops coming from tip of ureteroscope. When I've got access strip inside collecting system, I'm just using basic system structure, which is using for sinks. And if I'm seeing consistent flow from access strip, it means to me that there is persistent irrigation fluid and pressure inside collecting system is not risky high. What I'm also doing, I'm using suction, and I take three-way Venflon tap from anesthetist. I put one end on ureteroscope, and on other end I put irrigation fluid and suction. So first of all, when I dust stones, I can use suction to retrieve all fragments. And second, if I feel that I've over-distended kidney, I just put suction on and I drain the kidney. I know some people mentioned or suggested in the past that filling in, emptying the kidney can cause some bleeding, which decrease view inside pelvic ileal system. But I think that one is at the moment the cheapest way you can secure low pressure within collecting system. Now, second thing is overheating collecting system. And as you know, using frequency of fragmentation, laser fragmentation on 20 Hertz, only 52 of pulses are reaching the stone. When we increase frequency to 50, only 23, and when we increase to 80, only 4 of pulses are reaching stones. So again, we are getting frustrated, and we increased power. And when we increased power, we start overheating the kidney. And there was a study confirming that keeping temperature of 43 Celsius for 240 minutes is causing tissue damage. However, increasing a temperature to 53 Celsius, you need only 15 seconds, and kidney is overheated, and we are causing a significant damage. As we know, the higher energy delivered, when there is a greater increase in fluid temperature, and without irrigation, when we increase fluid inside the kidney to 50 Celsius, just after 10 seconds, we can cause the damage. And when we increase to 70 Celsius after 60 seconds. So, and what's also important, we know that when we increase irrigation flow, we are increasing temperature within a collecting system. And with irrigant flow of 40 meters per minute, temperature does not exceed 38 or 40 Celsius. As we discussed, access strip improves irrigation flow, outflow, prevents increase in intrarenal pressure. So we would suspect that it should also allow us to control temperature within collecting system. However, there is no evidence supporting that ureteral access strip can be used to reduce intrarenal temperature. Another trick to control temperature when we use a high energy setting laser is intermittent activation of laser for a couple of seconds, and then wait, stop for a couple of seconds, and then carry on with treatment. Whether it's 3 to 4 seconds, whether it's 9 seconds, it's if we remember to stop at some point and not get so enthusiastic that we keep on dusting stone and suddenly increase temperature to dramatic, just break, stop, and that one is a great advice. Safe temperature settings, if we are using low power laser, 10 milliliters per minute of irrigation flow, so sailing back slightly over 60 centimeter of water column should be safe. For 40 watt, we have to use much higher irrigation flow. And what some people advise now, instead of warming irrigation fluid, maybe using chilled fluid for fragmentation of stone at higher settings would be better to patient. So we discussed some safe issue, and I would like to talk to you a couple of minutes on how to introduce ureteroscope, how to do it safely. Myself, I prefer to ride completely empty highway rather than such a busy one. So I don't like to use guide wires, and I love to do procedure wireless and shiftless procedure. But how can we get ureteroscope into ureter? Of course, we can do it wireless and shiftless, even doing flexible ureteroscopy. We can do it over guide wire. We can do it next to guide wire, and we can use access sheath. Access sheath was developed first by Takayasu to improve insertion of ureteroscope, and using first piloureteroscopes, they had a lot of problems to pass intramural segment of ureter, and they said that there was like a kind of valve-like action. So that one is a first ever access sheath used just for ureteroscopy. But in the past also there were completely different ureteroscopes, and I remember when I started doing ureteroscopy, I was using 9 or 10 French ureteroscopes. So you can see with 9 French ureteroscope, even when you've got preoperative stents, 44% required dilatation of ureter, and with no pre-op stent, 86% of patients require dilatation of ureter. And it is, it's not very old paper, it's from 1997 from Kleiman and Nakada. So is access sheath good? Yes, it is, and it allows multiple passes of ureteroscope. It reduces operative time, it improves visualization, it decreases, as we discussed, intrarenal pressure levels. So it should prevent damage to kidney. When I use access sheath, I use access sheath when ureter is very tight, just to achieve low pressure in collecting system. When I deal with infected stones, when there is a high stone burden, just to dust and clear the kidney, and of course tighter ureter. And as you can see, we've got a different sizes of access sheath with inner diameter. The slimmest one is 9 French. Of course, when you use access sheath, we stretch ureter and we put quite significant tube into. So in 2013, Traxer reported quite significant rate of ureteric trauma from access sheath, up to 46.5%, although majority were low grade, so no significant lesions or just mucosal erosions. However, 13% were quite severe ones with proper perforation of ureter. So it is a bit scary before taking access sheath and trying to put into patient. My advice is, if you plan to put access sheath, always inspect ureter, trying to avoid such a disaster when ureter was not inspected, access sheath was placed into ureter and stone was pushed, causing perforation. A lot of studies on access sheath, and what's important, stricture risk is low. It's between 0.9% and 1.4%. And another recent study from 2022 assessing ureteral access sheath, conclusion is ureteral access sheath cannot be related to ureteral injury. Pre-stented patients are at lower risk of problems. If there is injury caused to ureter caused by access sheath, chance to progress it to chronic is low, and the risk of ureteral strictures is quite low. There are different access sheaths. That one you can see is a prototype of sheath with active suction, and you can deflect distal end of access sheath 90%. So with a suction, you can retrieve stones. What I used to do, I used to put stone in upper calyx, And after dusting on fragmentation, I used to put open-ended ureteric catheter through access sheath and flush it with saline, which can give you nice clearance of fragments. I believe you remember in the past, we used to have a flex or view access sheath. So that one was access sheath with optical fiber inserted through the access sheath and ability to deflect. And as you can see, that access sheath worked quite well as vacuum cleaner. You were able to get access sheath under eye close to all debris, and all debris is nicely drained outside. Plus, what you can see, we're able to deflect sheath, trying to get into calyces we wanted to drain. So it was access sheath bit rigid, so it wasn't like a flexible ureteroscope, but an idea of that access sheath was and the flexible ureteroscope with a big hole inside to drain all fragments. Now, myself, as I said, I prefer to do ureteroscopy as wireless and sheathless. And using ureteroscope is slightly different when using cystoscope. And you are working with two hands, and left hand is responsible for rotation of scope, and right hand does not. You are holding a shaft of scope, and right hand only deflects. Slightly difficult insertion of scope into through urethra into the bladder, but you can see you can nicely negotiate scope through urethra, and some people are saying it's difficult. I don't find any difficulty to get quickly into the bladder. As soon as we are in the bladder, I push scope much further just to get whole deflecting mechanism inside the bladder, and I start rotating, trying to find ureteric orifice. You can see inspection of the bladder is as good as with a cystoscope. No risk of missing anything inside. So we're trying to find ureteric orifice on right-hand side. And it is there. And now on left-hand side. And in a second, we'll be getting scope without access sheath and without wire into ureter. A bit difficult to get it. You'll have to be pretty patient, but as you can see, you are easily inside. Another example of insertion of ureteroscope into ureter. What's the most important? That one is post-ureteroscopy, post-fragmentation of stone. It was bilateral. Ureteric orifice and intramural ureter are untouched, looking very nicely, and on other side as well. That patient had a couple of stones in each kidney, and it was bilateral ureteroscopy, and I didn't leave stents, and patient was perfectly fine. If it is a bit difficult to get into ureteric orifice, I'm using wire, and I place wire into ureter, and ureteroscope goes very easily over guide wire, as you can see. As I'm saying, a bit of patience. It's slightly more difficult than putting rigid ureteroscope, but it's achievable. Insertion of a guide wire when you can keep ureteroscope inside and get it under eye, it's, I think, a bit of overuse. And what's the most important, you can see that one, that scope was inserted under X-ray guidance, not under eye. So I would not support putting a ureteroscope blindly when you can assess whole ureter on insertion. Sometimes we need guide wires, and I love either bi-wire or sensor wire, which can pass every kink inside ureter. You can see that one is quite significant kink in proximal ureter. Advantage of flexible ureteroscope is as soon as guide wire is in, you can slowly negotiate ureteroscope, and you can even pass such a 360-degree kink. I never use Amplatz super stiff wire, putting access shift or negotiating ureteroscope with a, it's good wire when you are doing PCNL, but you lose filling of tissue and it's very easy to perforate or even cause avulsion. That one is one of examples of difficult kink ureter, which you cannot pass with just ureteroscope, and that one is insertion over guide wire, which appeared to be much easier. You can see it's still trying to get with ureteroscope, and we are putting guide wire. And what I'm doing, I just put guide wire, and even I don't try to push guide wire as far as possible. I keep it just in front of scope, pushing scope with guide wire. So guide wire is finding the way through ureter, and then slowly you can follow it and you can reach renal pelvis. What to do? I'll be finishing soon. So what to do if we put ureteroscope and we cannot pass ureter is too tight, and we cannot put access shift. It happens up to 10% cases. If it is long, I leave a stent, and as I said, I bring patient within 1 or 3 weeks time. If it is short, I try sometimes to balloon, and you can see if you are using balloon to improve insertion of ureteroscope, risk of perforation is low and risk of post procedure stricture is quite low. What I can do, you can see on that picture, quite narrow segment of ureter. I ballooned it and I placed access sheath proximal to that narrow segment. So narrow segment is secured. I broke stones, and then I withdrew the ureteroscope, and you can see ureter didn't look very traumatized on retrieval, and I would say Traxer's grade 1 trauma only, so nothing very serious, and we managed to deal with the stone. So if it is short, sometimes I do it, or if it is short stricture, I do ureterotomy with a laser. That one is one example, and it cuts very nicely if it is really very short segment of ureter. Of course, we have to cut it more. And I do it like a proper ureterotomy. So I cut it to periureteric fat, what you can see on that clip. So it was nicely done. In such a case, I would not try to deal with stone or put access sheath. I would just leave it, heal it, and then deal with stones. Quite important thing when you do ureteroscopy, kidney sometimes starts moving very fast suddenly. Then speak to anesthetist, because either patients start feeling pain, or ask yourself, because maybe collecting system or bladder are over distended. Also, when I get the first time into kidney, I observe a breathing pattern, because as you can see, that kidney is moving quite fast, but there are periods of time kidney stops moving. So I observe how kidney moves, and then I use it for fragmentation. Of course, sometimes kidney is moving terribly, and you cannot break stone or do anything. So in such a case, what I do, I put stone into basket, and I break it inside the basket, and that one allows me fighting and wasting time struggling with renal movement. And the last thing, always, if you are dealing with stones or doing anything inside collecting system, if it is stone, try to move stone into calyx, because as you can see, you can have blood vessels all around pelvis. So also observe kidney for pulsation. And I remember one of my colleagues, it wasn't ureteroscopy, it was PCNL. When he was breaking stone with lithoclast, he just pushed stone fragment into renal artery. So be careful and try to stay away from pulsation. So in summary, what are rules? What can we do to be a gentleman inside a ureter? First of all, fluoroscopic stuff equipment must be in theater. It's when you start doing ureteroscopy, or if you are not very keen on doing it wireless, place safety wire. It is recommended. Of course, you can learn how to do wireless and shiftless procedures. If intramural segment of ureter is too tight to put ureteroscope, I always negotiated with semi-rigid ureteroscope, doing optical dilatation over guide wire, not next to guide wire, just to open ureter. If you are using access sheath, tip of sheath needs to be at ureteropelvic junction or renal pelvis. If in proximal ureter is narrow, always remember that pumping of irrigation fluid more and more does not improve vision and creates very extreme high pressures inside collecting system. And don't get excited using laser, because you can very easily overheat the kidney, which is not very great. And Mr. Lyon was a first urologist who treated upper tract ureteric tumor with a pediatric cystoscope, but ureteroscopically. And he used to say that if care and thought are practiced, then you should not have any complications. Thank you.
Thank you very much, Greg, for a comprehensive talk on various safety features and technical challenges. And we would really welcome any questions from our colleagues, please, from Dr. Kata.
Dr. Carter, thank you very much. Dr. Nazim from Aga Khan Hospital, and I congratulate you, and I'm very thankful for covering almost all the safety and technical aspects for the flexible ureteroscopy. So my question is, because you mentioned that you prefer not to have a guide wire, either a side guide wire or a navigator guide wire or access sheet. And you mentioned about the different aspects such as intrarenal pressure, intrarenal temperature. So what is your opinion? The first question is, what is your opinion about routine placement of double J stent if you want to avoid the access sheet and easy passage of the ureteroscope? The second question is may or may not be relevant, but as you mentioned that the laser energy and the time during the ureteroscopy can have damaging effect to the upper tract by increasing the temperature, by increasing the pressure. So we know that the thulium laser has a much higher efficiency in fragmenting the stones and dusting the stones compared to holmium laser. So, so can we say that thulium laser is also much safer as compared to holmium laser? Thank you.
So answering to your second question, we get high temperature when we are using high power lasers or high power procedures. So when we put 20 watt or 40 watt on laser, if you are using lower, just like maximum 10, I think it is safe. And I still think thulium laser is not fully investigated, but I recall 1 or 2 studies saying that the risk of heating with thulium laser is similar to holmium laser, so it is the same. Now, speaking about safety of insertion, access sheath and pre-stent, I know a lot of endourologists favor insertion of access sheath just before ureteroscopy for bigger stones. So, for example, when we've got a patient coming in colic with big stone or stone in renal pelvis closing obstruction, I always recommend putting a stent. For bigger ureteric stones, I would not recommend doing primary ureteroscopy. I would put stent and have a more favorable ureter to deal with stones. Now, what I said, it does not mean that I do not use access sheath and I do not use wires. I use wires if ureteroscopy is going to be difficult. I leave sometimes safety wire if ureter is very kinked, because that one shows me the way to kidney. And every time I do ureteroscopy, I put flexible ureteroscope first. I inspect whole ureter, and if ureter is wide open, with diameter much wider than ureteroscope, then I do it without access sheath. If ureter is tight and it looks like when I start putting irrigation fluid through ureteroscope and it stops, kidney is over distended, I would never do it without access sheath, and I would keep access sheath in renal pelvis, especially now if we dust. So, and also not using access sheath is I dust stones, and I had a lot of patients. I managed to dust stone, and then I took syringe and I aspirated all dust, and that was it. So no need to retrieve stones. But still, I love not to put wire. I love not to put sheath, but it does not mean that every patient is treated that way.
Thank you very much, Nazim. Anything else you would like to comment on or add?
So I think I have put one question on the chat, that whether access sheath is safe in children, for example, children below 30 kg of weight or small
I
children.
do not do children, but at some age, I mean, elderly children, people are using access sheaths, and they are using, as far as I remember, 9 French access sheaths. But I cannot comment. I do not do pediatric patients, but I know that some papers saying that it is safe to use them in children.
There is one question from Professor Nasir Oretzai, that whether it is advisable to use diuretics in cases of prolonged flexible ureteroscopy. So would you prefer to use diuretics while you are doing a bigger stone and managing it by flexible ureteroscope?
You mean to preserve renal parenchyma, or just to deal with, because giving diuretics means adding more fluid. So if you don't have ensured good irrigation flow, then it can cause overdistension of kidney and increase pressure within pelvic LCL system. So for simple hydraulic stuff, I would not give diuretic. And that question we need to ask our nephrologists what they think. It rings a bell that some people in the past used to give diuretics, but I don't know if it can help, just building higher pressure in tubules just to prevent backflow of irrigation fluid into tubules. I cannot comment. Atanas, do you have any experience with diuretics?
Usually we don't advise the anesthetists to give them. I mean, it may do more harm than benefit. So I wouldn't advise for diuretics, to be honest.
Thank you very much. Any more questions in the chat box, or anyone have? No, I cannot see. So I think with this, I would really like to thank both our respective speakers for their time and sharing their expertise, Professor Pavsoris and Professor Kata, and all our Aga Khan team for organizing this, and all our contributors, delegates attending, their contribution. Special thanks to Dr. Nazim, one of our senior faculty in Aga Khan, for his input during the lectures. And have a very good evening and Sunday tomorrow, and hopefully we'll be meeting again soon with this series by Professor Hamad Attar, we have to really appreciate his commitment to continuing this for over 1 year now. So thank you very much, everybody.
Bye-bye. Thank you.
Bye.
Thank you. Bye-bye.